So, welcome to everyone to our medicine learnings. Welcome, Dr. Nishant Pandey, especially today, Dr.
Thank
Bermio.
you so much.
Okay, it's okay. Pleasure is ours. Today, Dr. Bermio will be taking class on management of diabetes, especially. Today, he'll be talking on insulin, various types of insulin, and how you go about with management. Thank you. Over to you, Bermio, sir.
So shall I start?
Okay,
Yeah, it's going fine. No recording is in progress.
it's going.
Yes.
Okay, so we'll start. So this is the second part of the continuation of the last lecture. In last class, we discussed about the pathophysiology of diabetes, then some basics about the nutritional therapy in diabetics, and all the classification of drugs in diabetes, how to initiate, how to proceed. We went on. So even in the last class, we discussed a few basics about insulin. So can any one of you remember the indications for insulin, which I told in the last class? It goes Daniel.
Yes, I remember. I will indication of insulin. One was diabetes with cachexia.
Okay,
Then,
first is type 1 diabetes manifesting variably.
yeah,
In type 2
type 1.
diabetes, what you told is right. T2DM with
Diabetes.
cachexia.
Yeah.
Because insulin is an anabolic hormone. So whenever a type 2 diabetes patient, rather than being obese, if he starts to lose weight, that definitely becomes an indication to start insulin. Next.
Yes. Next is a critically ill patient.
Any hospitalization. A diabetic patient, whenever he gets hospitalized for whatever reason, be it for a surgery, be it for a critical illness, for an ICU care, preferably we have to give insulin because giving oral hypoglycemic agents will cause so much of drug interaction. They will not have a predictable absorption and predictable action. Whereas insulin is not so. So for any hospitalized patient, be it a critically ill patient, we have to start preferably on insulin.
then if it is
Pivot
not
loss.
controlled, what?
Yeah, not controlled with
Not controlled with 3 OHAs, we can add on insulin.
Diabetes not controlled with 3 OHA. So last class I was telling about how to monitor OHAs. So HbA1c
Yes.
should be measured every 3 months, right? So we have
Yes.
started one drug, we have titrated the dose to the maximum dose. We have had 3 attempts. So 3 months, 3 months, 3 months, and another 3 months for titration we can take. So roughly 1 year. At the end of 1 year, with 3 OHAs, if you are not getting control with diabetes, that becomes an indication for insulin.
Adding
Next.
insulin, right?
Yeah, adding insulin. When you add insulin, you should not give a few drugs. What are they?
Which cause hypoglycemia.
Insulin causes hypoglycemia, so other drugs causing hypoglycemia should not be given. What are they?
Oh, yeah.
Glymeteride, sulfonylurea.
SLT, yeah. Sulfonylurea, yeah.
SGLT2 inhibitors don't cause that much of hypoglycemia. They are just only
Okay.
add-on drugs.
Sure.
Sulfonylureas and meglitinides. These should not be given, or they should be reduced in dose. Because all these 3 agents have a risk of hypoglycemia. If you put all these 3 together, patient will definitely have hypoglycemia.
Sure. Then mean blood glucose more than 300. We have to add on insulin.
Yeah, or HbA1c more than 9. Mean blood glucose, as the initial presentation is more than 300, or HbA1c is more than 9, or any point in the patient's history of diabetes, sugar crosses 300, it becomes an indication for insulin. Then
that is even with one value of 300, huh?
One value cannot be taken as such, persistently high 300. That's why HbA1c has more value. HbA1c more than 9 means the overall 3 months sugar itself is more than 300. That's what it means.
Okay.
because a single value of hyperglycemia may not be significant, but many
Okay.
values are more than 300, that will become
Hmm.
significant.
Sure.
Then
Diabetes
diabetic
with end organ
emergency.
damage. Okay. Yeah.
Okay. Actually, hospitalization includes diabetic emergencies, DKA,
Hmm.
hyperglycemic, hyperosmolar state.
Okay.
Then what you told is diabetes with complications.
Yes.
So diabetic nephropathy,
Hmm.
diabetic neuropathy,
Hmm.
such complications comes, preferably you have to give
Insulin.
insulin. But the ultimate aim of giving insulin is you should prevent the complications. So it is
Okay.
better to start insulin in the early stage of the complications to prevent progression. Once there's a full-blown diabetic neuropathy, nephropathy, there is no
Hmm.
point in adding insulin because once diabetic nephropathy and CKD occurs, this itself becomes a risk for hypoglycemia,
Okay.
right?
Diabetes
So
with
at that stage,
sepsis.
if you give insulin, sorry,
If there is a sepsis condition, if patient is in oral hypoglycemic, we should always
hmm,
shift to the insulin with a minimal sepsis also. If count is high or patient
preferably,
has some.
preferably.
Okay.
That's what any hospitalization, preferable to use insulin because definitely we will be giving so many drugs. Some amount of drug interaction may be there, which will make the diabetic control with OHS unpredictable. So preferable to use insulin. Of course, it's an initial individual's choice only. We can give oral hypoglycemic agents, but the ideal one is to use insulin as far as possible.
Hmm.
Suppose if the admission is not a critical one, they are just admitted for an observation sake with no illness, we can continue this. That is, their food has not changed, patients are not sick, their values are not abnormal. In that case, we can uh, continue the oral hypoglycemic agents. But if there is some sickness in the patient, preferably use insulin.
Okay.
Okay. Uh, I think these are all the indications for insulin. Okay. So before going to the next aspect, what are the
Hmm.
insulins you know of? We'll change
Human
the colors.
Insulin.
Okay, all the insulins we are going to discuss is human insulin only.
Yeah.
who are comfortable there.
Can you classify based on the duration of action?
Yes.
Yeah.
Very ultra short acting. Is that short acting?
Hmm. Ultra short acting is also called as rapid acting insulin.
Rapid acting.
Next comes short acting insulin.
Hmm.
Next comes
Intermediate, right?
intermediate acting insulin.
Hmm.
Next comes long acting.
Long acting.
Next comes longest acting.
Okay.
So ultra short acting, intermediate acting, long acting, and longest acting. So you should know about each names. So ultra short acting will be the insulin analogs. Insulin aspart, lispro, and glulysin.
Okay.
So many trade names are available like aspart comes as Fias. Okay, so aspart, lispro, and glulysin.
Aspart comes as?
Apidra is also aspart is called as Fiasp in the market. Lispro is called as Apidra in the market.
Oh, Lispro is Sapidra. Okay, okay. That's what RJ
Yeah,
ಅಲ್ಲ
told me.
Apitra is glulisin ಅಲ್ಲ.
glulysin.
Yeah.
Okay.
Amylin.
Okay. Anyway,
Glucosin,
Apidra
huh?
and Fias
Okay.
both are ultra short acting insulin.
Okay.
Short acting we have the so-called R, the regular insulin.
Okay.
Sir, can you please close these side windows?
Side windows cannot be closed. It will expand only.
Don't understand.
Okay. So short acting is the R or the regular insulin. In government setup, we have only two insulins: the short-acting regular insulin and the intermediate-acting N insulin, also called as NPH insulin or isophane insulin.
Okay.
What's the trade name for regular insulin?
Actrapid.
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 So Apidra is glulysin, Actrapid is regular. Intermediate is isophane insulin or N insulin. NPH, they are the names. Long acting is also an insulin analog only. So Aspro, Lispartan, glulysin are ultra short acting. Here we have Glargine. Glargine comes in two forms: Glargine U100, Glargine U300, Determined. Longest acting is Degludec. So long acting or longest acting? Glargine U100, U300, Determined, and Degludec. Longest acting is Degludec. Okay, so clear with this one, the duration of action of insulin.
Yes.
Why
So
you
can you
should
show
know
that
this
long
separately
acting?
is
Can you show that long acting Glargine and
Glargine U100, Glargine U300, Determined. Longest acting is Degludec.
Okay.
Okay. If you are very thorough with this concept, I'll tell you the duration of action of insulin. So for any insulin, you should know the onset of action. When does the insulin start acting? Then you should know the peak action, when there is a peak. Then you should know the duration of action. These are the three important things you should know for any insulin. So we'll take, for example, ultra short acting insulin. Aspro, Lispart, glulysin, or Apidra, Fiasp, whatever it is. Its onset of action is less than 5 minutes. So you are injecting, you start eating. The gap between injecting and starting to eat definitely will be less than 5 minutes. As you start eating, it starts to act.
Okay.
Peak action will be in 15 to 20 minutes.
Okay.
Duration of action is 4 hours. Okay.
Okay.
Actually, history-wise, which came first? Regular insulin came first. The problem with regular insulin is it starts to act in 20 to 30 minutes. The peak action around occurs in 1 hour. The duration of action is 4 hours. That is why while giving regular insulin, we have to wait for 30 minutes for it to start acting. So you are injecting immediately, and if you are taking the food immediately, it will cause a rapid rise in sugars in the body. It will be difficult to control later. So if you are giving an insulin, you should start taking the meal at the 20th minute or at the 30th minute.
Okay.
But the duration of action for ultra short and regular both are same, only 4 hours.
Okay.
Now come to the intermediate acting insulin, NPH insulin. Onset of action is 2 hours. Never forget this word. Okay. Onset of action of NPH is 2 hours. So if you give a NPH dose at morning 10 o'clock, when does it start acting?
12 p.m.
Okay, so that's
12 p.m.
for 2 hours it will not act at all.
Mm.
Okay, so NPH starts acting in 2 hours. Peak action will come in around 4 hours. Duration of action is 18 hours. This also you should remember.
Okay.
So duration of action is less than 1 day, just less than 1 day, 18 hours.
Okay.
Now the long acting and ultra long acting will be more than 24 hours. So 24 to 26 hours, 36 hours will be the actual one. They start to act around 1 hour, we can say. But the most important thing is there is no peak for long acting. So whichever long acting insulins I told you, Glargine U100, Glargine U300, Degludec, Determined. What is Lantus insulin? Glargine. So if someone asks you the benefits of Glargine, it starts acting in 1 hour. It has no peak, and it lasts for 24 to 36 hours. If someone
It's
asks
pretty
you
good.
about intermediate acting insulin, it
Hmm.
starts acting in 2 hours, it
Hmm.
peaks in 4 hours, it lasts for 18 hours.
Okay.
So the main difference between N insulin and long-acting insulin is one is the duration of onset of action will be slower in intermediate. There is a peak at 4 hours, and its duration of onset is less than 24 hours. Whereas
Okay.
long-acting or latent insulin, it starts acting a bit earlier.
Hmm.
There is no peak. This peaking effect is also called the shoulder effect.
Okay.
Okay, so for regular insulin, ultra short acting, intermediate acting, we have the shoulder effect. But for long acting insulin, there is no shoulder effect, and duration is large, not longer. So, which is more physiological, and this is more physiological. Why I am telling is physiological is what's the normal basal secretion of insulin per day? Basal means you are not taking any food, but the body will be still producing insulin at a particular rate. What is that rate?
Not
1
sure.
unit per hour,
Oh, okay.
which means per day 24 units is the normal basal insulin produced. Even if you don't take any meal, your body will be producing insulin at 1 unit per hour. That is 24 units per day. This is the normal insulin produced by an individual. If a particular individual produces more than this is abnormal.
Okay.
Okay, correct. So this basal concept brings another concept called as bolus secretion.
Okay.
What is bolus? If you take a meal,
Hmm.
the amount of secretion will increase suddenly. Let us draw a graph like this. 1 unit per hour is secreted. This is the basal secretion of insulin. It will be static. 1 unit per hour is the actual take.
Hmm.
After taking a meal, what happens? Suppose this is the breakfast time now. A sudden increase in insulin secretion occurs to cover the morning meal.
Okay.
Afternoon meal contains more sugar, so there will be a very high increase in insulin.
Hmm.
Suppose they are taking an evening snack, a small rise in insulin. Again, dinner they are taking this one. So this is the basal secretion, which is 1 unit per hour. This is called as the bolus secretion of insulin. So understood the terms basal and bolus.
So this is produced by the body itself.
This is the
Is it
normal physiology in the body.
normal
Yeah.
physiology?
So why I am telling this is basal secretion, you can very well see there is no peak. It is continuously produced. It's secreting for 24 hours.
Yes.
So which insulin among all the ones which I have mentioned mimics the basal secretion of insulin? No peak,
No peak.
continuous
So
action,
it's long
longer
acting.
duration of action. Long acting insulin. So that's why long acting insulin is preferably used as basal insulin. I'll tell you what is basal later.
Okay.
The next best will be intermediate because of the longer duration, 18 hours. But what's the disadvantage? There's a shoulder effect, which is not present in the normal physiological secretion. Right?
So
Okay, so
that,
till now
that
what I
point again, long acting insulin is used as basal. That I understood.
long
Because
acting is the best insulin which can be used as a basal insulin because it is more physiology.
okay.
The next best insulin to long acting insulin, suppose if long acting is not available, you should go for an intermediate acting insulin. But what is the disadvantage of intermediate acting insulin? The shoulder effect or a peak effect
Okay.
at 4 hours. What is the disadvantage of the 4th hour peak effect? It will cause a hypoglycemia at that.
Okay.
Okay, so that's the same example. If you are giving a young insulin at 10 a.m. in the morning, it starts acting at 12 p.m. So
Okay.
2 hours, there's no cover of insulin.
Yes.
Its peak action occurs at 4 hours.
4 hours.
So at 2 o'clock, if you are not taking any meal, patient will develop hypoglycemia.
Yep.
Come to a more practical example. Night time, usually we give N insulin, right? Long acting insulin, if you are giving in the night, last dose will be taken at 10 p.m.
Okay.
Okay, from 10 to 2, there will be no action of insulin at all.
Yes.
12 o'clock, it starts acting.
Okay.
Peak action occurs at 2 o'clock.
12
12 o'clock to 2 o'clock, 12 o'clock to 2 o'clock is the time when they are prone for hypoglycemia.
Okay.
Right? So you would have heard the term the midnight sweating is more suggestive of nocturnal hypoglycemia. This
Yeah.
is because of the shoulder effect.
Okay.
So 2 to 4 hours is the time when there's a peak effect of N-insulin where they go for hypoglycemia. To prevent this only, night time, you have to take a snack if there's a
Okay.
hypoglycemic episode.
Okay.
Okay. So till now we have discussed the indications for insulin, the classifications of insulin, the basal bolus secretion of insulin, and types of insulin.
Okay.
We'll go to the insulin regimens. Any doubt here? You can always stop me if you can't understand.
Okay.
Okay.
So
So
far
next,
good.
before going to so far good only. Okay. Before going to chronic diabetes, we'll first describe insulin management in diabetic emergencies or management of diabetic emergencies. What are diabetic emergencies?
DKA.
Ketoacidosis.
DKA, hyperglycemic, hyperosmotic state, hypoglycemia.
Okay.
Yeah, HHS, DKA, hypoglycemia. These are the 3 diabetic emergencies. Hypoglycemia is not the discussion today.
Okay.
Okay. I won't discuss about the pathophysiology of DKA. You know very well if there's an absolute deficiency of insulin, the body will go for more lipolysis. Excess lipids, fatty acids get converted to ketones. Okay, and since insulin is completely absent, sugars will be high. The excess ketones, excess fatty acids, excess sugars will be excreted by the body to cause a dehydration.
Okay.
And excess acetone will cause acidosis, acidotic breathing will cause dehydration. Finally, what leads is the ultimate pathology in DKA is dehydration.
Okay.
So if a patient comes with diabetic ketoacidosis, like high sugars, the criteria for DKA is sugars more than 300, acetone positive, and then the acidosis, pH less than 7.25, I think. If
This
these 3
acetone should
criteria are
be
positive,
blood acetone or urine acetone?
anything.
Okay.
We have blood acetone, so we check it. But in outside hospitals, when it is not available, we do urine acetone.
So, okay.
Suppose if urine acetone takes a time to occur, we correlate with these 2 things: high sugar plus acidosis of obviously diabetic ketosis. Mostly.
Right.
So
What
whenever
can
this
be
criteria for
what can be the inference of having acetone positive in urine? I mean, what inference we should get? We should think.
High sugars plus acetone in urine, it means it is diabetic ketoacidosis. Because in HHS, there will be high sugars, but acetone will be negative. The treatment is nearly the same. We are going to hydrate them. We are going to give insulin. But DKA is even a more dangerous condition than HHS. Because the body's metabolism is completely altered in DKA. There is fat is going for lysis, protein is going for lysis. So it just gives an indication that we should be even more alert than HHS.
Okay. But even with the sugar of 250 and all, we can get urine and blood acetone positive, no?
There is something called as walking ketosis. Patient sugars will be normal, but ketosis will be present. One typical example for that is patient taking dapagliflozin. Last class we discussed. Euglycemic ketosis. Euglycemic ketosis. Similarly, patients with very chronic diabetes. Some chronic diabetes also can present in this way. There will be urine acetone positivity will be there. They will be coming with symptoms of ketosis, but sugars will be less than 300. So in that case, if urine acetone is positive, with the history of diabetes, we can make a diagnosis of DKA and treat them accordingly. Don't think about insulin at all in management of DKA. Some may think ketone is positive, sugars is 220. So how much insulin to give will be the confusion of most of the people. Never think of insulin while managing DKA, because the first treatment of choice in DKA is fluids and fluids only.
What do you mean
At least
never
take
think
this
of
point.
insulin?
But like,
You mean starting?
never think of insulin is never think of starting insulin first.
Okay.
When I was a PG, whenever I see a sugar of 450
We will give.
DKU, acetone positivity, pH of 7.1, I was tempted, everyone was tempted to give insulin. But my assistant
Yes.
professor came and told one thing, only fluids is important. Then on, we gave only fluids to the patient. Even when insulin is during COVID crisis, there are times when insulin was not available, not accessible. Only
Okay.
fluids was given and managed.
Okay.
Remember, high sugar is not going to kill the patient. It is the
Low
altered
sugar.
metabolism, it's the dehydration which is going to kill the patient.
Oh, sorry.
So never
So
forget this
fluid
thing.
of,
Fluids.
so fluid of the choice will be RL or normal NS.
Normal saline will be
Normal
the
illness.
fluid of choice. Yeah, normal saline.
Yes.
That's a separate reason for that. We'll discuss that later. Actually,
Okay.
oral can be given, but usually what they say is since lactate is high, it may increase the acidosis in DK. That's why lactate is not given. So NS is the preferred option. And that's a simple formula. 2 pints to be given over 1 hour. Next 2 pints to be given over 2 hours. Next 2 pints to be given over 4 hours. Next 2 pints to be given over 8. So 1 liter over 1 hour, 1 liter over 2 hours, 1 liter over 4 hours, another 1 liter over 8 hours. The total deficit in DK will be 4 to 6 liters of water. That's 4 to 6 liters of water will be lost in DKA. We are replacing 60 to 70, 50% of that. We are replacing in the first 6 hours. Correct? In 7 hours, we are replacing 3 liters. The remaining fluid should be given over the next 24 hours. So it's a simple mnemonic. 2 pints over 1 hour, 2 pints over 2 hours, 2 pints over 4 hours, and 2 pints over 8 hours.
Just one doubt, sir.
Ah.
This is based on practice or is it like the textbook guidelines? This,
Textbook guideline says that the total fluid loss is 4 to 6 liters. 50% of that should be replaced within the first 6 hours. This is a practical hint.
Sure. Okay.
So it will be easy to give instructions.
Yeah.
Okay. Once fluid is done, the second most important thing you have to correct is the potassium. Because you are going to give insulin in the third step. If you give insulin, definitely they'll go for hypoglycemia. Never give insulin without seeing potassium.
Yes.
The potassium, 3 possibilities are. Potassium is low. Potassium is normal. Potassium is high. If potassium is low, definitely you have to replace it. Right?
Yes.
So practically in what we do is we give 2 ampules in one side fluid is going on, so 2 ampules in 1 pint of saline. It should be given over 4 hours. This is our replacement dose of potassium. Every hospital has its own protocol. I am telling what we followed in our hospital. Suppose K plus potassium is normal, definitely they'll go for a potassium loss on insulin.
Yes.
You have to give 1 ampule in 1 pint NS for 4 hours. And this should be done in every alternate. Okay, so every alternate fluid containing 1 ampule potassium will supplement potassium, which is going to be reduced by giving insulin. Potassium is say there is no role of potassium replacement. You can directly go to step 3.
So
Step
one
3
doubt.
is only insulin.
I didn't understand the second one. Potassium normal, 1 ampule in 1 pint
If
NS.
the potassium is normal, over 4 hours you have to infuse 1 ampule of KCl. Next 4 hours there should be no KCl.
Oh, like that.
Next 4 hours you have to give another KCl.
But no, the
I
problem
told
is that
no, 2 pints over 1 hour.
Oh
we
yeah,
are
yeah.
giving
2
fluid
pints only.
very fast now. So within 1 or 2 hours, 1 hour we will be infusing 1 pint, 2 pints. So we have to start an alternate line. No?
Another line, huh?
Another line. Another line over 4 hours you have to give. Next 4 hours you have to take a break.
Okay.
Next 4 hours you have to give 1 ampule. It all depends on how you treat only. Suppose if line is not accessible, Usually what we do in practice is we'll start 2 lines. 2 lines will be going on with fluids. One paint will be fluids alone. Another paint will be giving KCl or bicarbonate or something. In the practical side. So one side fluid will be in a continuous flow. The other side will be giving either potassium or something. So when that second fluid potassium is over, that will be going slowly over for us. When that finishes, we'll start the next fluid only with NS. When that finishes, we'll start with potassium. Suppose if you are having an infusion pump, means we can give potassium in an infusion pump in a guided manner. In that case, 1 ampule over 4 hours, then 4 hours break, then the next 4 hours. If potassium is low, you have to continuously infuse potassium till potassium increases.
Okay. Just one thing, 2 more minutes left in this meeting.
Okay, then we'll close and we'll start a new one.
Okay. So, can I summarize this potassium thing? Oh, this is the treatment part. So, practically, so if we start in one line, fluids like NS, 2 pint over 1 hour, then 2 pint over 2 hours. Let that go in this right hand, and in the left hand, I mean, whatever, we need to start off with potassium correction. If the potassium is low,
We'll start with another line.
Another line with
Potassium
fluids
is
just
low, we'll
over
start with the
4 hours
potassium
we'll
correction
give.
in the other line.
Just so we can give in the other line fluids 1 pint over 4 hours and put 2 ampule in that, right?
Yeah.
Can we
Then
do like
again
that?
continue with the potassium in the same line.
Okay.
Every hospital has its own protocol. We did like this.
Sure.
But the thing is, you have to replace potassium. That's the only thing.
Okay.
See, for potassium in infusion, that's a separate guidelines. No, totally, we should not give more than 80 millimoles per day.
Yeah.
1 ampule is 10 millimoles, right? 20 millimoles. 1
20.
ampule is 20 millimoles. So you should not give more than 4 infusions per day.
Okay, I'm stopping recording.
Okay. This is the simple general guidelines regarding how to give fluids and how to give potassium. Every hospital has its own guide. But what I have to remember is fluids we have to replace 4 to 6 liters. 50% should be given in 6 hours, and the remaining deficit should be given over the next 24 hours. Yes, around 4 to 6 liters should be given in the first 6 hours. The remaining deficit should be given over the next 24 hours. This is for fluid. If potassium is low, we have to supplement potassium. If the potassium is normal, we have to prevent fall in the potassium. So that will be around half the dose of potassium. Okay. Whereas potassium is high, we need not supplement potassium. That's all you have to remember. Then the third step is insulin. Okay, what the textbook says is 0.1 units per kg of insulin. Okay. Subcutaneous is what is given there. Some books say we can give it IV also. So for a 60 kg person, 6 units IV stat or 6 units subcutaneous stat can be given. Okay. Next
Which
is
do you prefer,
we have
IV
to
or
maintain
subcu?
it as what they taught us in MMC is there is no use in giving the stat dose.
Okay.
Okay. See what explanation they gave to us. No. You know the concept of half-life, right? That is, you know very well that it takes 4 to 5 half-lives for a drug to take its peak effect.
Yeah, peak effect.
Peak effect. If you are giving a stat dose, it will not have any effect at all. The doses will not be maintained in the body. So for this insulin to take action as IV, you have to give 4 to 6 doses of IV. IV half-life of insulin is 5 to 15 minutes, I think. 5 minutes. So every 5 to 10 minutes, you have to give 6 units of insulin. Only then it will be achieving a peak concentration in the blood. Subcutaneous dosing is different because it will be like a depot in this subcutaneous tissue and it will be releasing slowly. But if you are giving it as an IV, it will take some longer time for action. That is why MMC they taught us do not give this.
But at least at least giving a stat dose means it will decrease the sugars for the time being.
Textbook says that we can give stat. Textbook
And
say that
other,
we can use that.
another thing is that no, this the DK patient will be dehydration and all, so it's better to give in IV, no, rather than sub-Q.
It's
So
better to give
absorption.
an IV. Book say that subcutaneous or IV or IM, but preferably to give IV or IM. Dehydration, IV is better always. Okay. So 0.1 units per kg of insulin, IV. Then 1 unit per kg per hour infusion. Preferably or an infusion pump. That will be better. So what they do is 50 units of insulin will be taken in a 50 ml syringe and they'll keep it 6 ml per hour, which is equal to 6 units per hour. But the most important thing is not starting insulin. You have to monitor every 1 hour.
Which insulin should be started for this, like ultra short acting?
Regular insulin.
Regular insulin.
Both
But
can be used, but in my practice, regular insulin. Hello?
No. Okay.
6 ml
I
per
haven't used
hour.
Apidra. If you mix 50 units of insulin in 50 ml syringe,
Okay.
then 1 ml equal to 1 unit.
Yeah.
Based on your
6
dilution.
ml per hour or 6 units per hour. Okay.
6 units per hour. Suppose if infusion pump is not available, you have to mix insulin in 500 ml NS and give it. So based on your dilution, you decide accordingly. But unit of infusion is 6 units per hour. 0.1 units per kg hour of infusion. You have to repeat after 1 hour. The fall should be 10% of the initial value.
We didn't get that. Can you please explain it once more?
If a patient with DK, initially you have started fluids in one line. You have replaced potassium in the other line. Now you are planning to start insulin. Okay. So initially you are giving 0.1 units per kg insulin IV statin. You are given this. Then you have to start insulin infusion. The dose of insulin infusion is 1 unit per kg per hour. I'm sorry, 0.1 units per kg per hour. Okay.
Oh, it's 0.1,
so
right?
For a 60 kg person, 0.1 units per kg per hour will be 6 units.
6 ml per hour.
0.1 units. I think I made a mistake. So 0.1 units per kg per hour means it is 6 units per hour of infusion. Okay, so you have started the infusion. After starting, you have to do hourly sugar monitor. Hourly sugar monitor. How to say that your infusion or your treatment is successful means at the end of 1 hour, the sugar value should have fallen by 10% of the initial. For example, if the initial sugar value is 540 milligrams per deciliter, 10% of that is 54, right? 10% fall means 540 minus 54 will be 486, right?
Yes.
Okay.
So if the initial value is 540, at the end of 1 hour, it should become 480. This is the actual fall which you are expecting. Suppose if the value is not this much, it is still 510. So the fall is not as expected. You have to increase the insulin by 1 unit per hour. So initially, you are getting 6 units per hour. The sugar is 510. In that case, you have to make this as 7 units per hour.
Okay.
Again, continue for 1 hour. Repeat the same. Fall should be 10%. So 10% of 51 will be 10% of 510 will be 51. So around 460 should be the sugar. If it has fallen, continue at the same rate. So keep continuing the same. Suppose if the fall is excess. Okay, if the fall is in excess. So initial value was 540. We expected it to be 486, but it has suddenly become 436. The fall is in excess. You should never allow this because when sudden osmolality changes, it will lead to cerebral edema. In that case, you have to reduce the insulin by 1 unit per hour.
So it means that the only 10% of the initial value should fall now.
Yes. The fall should not be more. The fall should not be less. If the fall is less, you have to increase the insulin dose. If the fall is high, you have to reduce the insulin dose.
Everything by 1 unit per hour. And recheck after 1 hour.
Till 1 unit per hour. Recheck every hour.
Yes.
Okay. Now, when will you stop this infusion?
That is my doubt.
The next question. Hmm.
Urine has turned negative. Huh?
Urine aston will take a long time to settle. First, this patient is clinically stable. He should not be acidotic. He should be able to clinically take food. The patient clinically better. That's the first criteria.
Okay.
Some say that we can say blood ketone fall. Urine acetone will take a longer time to fall.
Hmm.
So you can take blood ketone fall. So blood
Okay.
ketone has fallen. Patient is clinically better. Then comes the sugar value. Clinically better means there is no acidosis. That's also meaning. A
Okay.
patient doesn't have acidosis. Patient has clinically improved from his condition. He is able to take feeds.
Hmm.
Blood ketone has fallen.
Hmm.
And the sugar value depends upon different protocols. Our hospital protocol was 250. So when the sugar falls below 250,
Hmm.
we decide accordingly.
Okay.
So either of these criteria should be there, no? Or all four should be there.
Suppose if the patient is not able to take feeds, he's in such a situation, he's not able to take feeds, means also we can change the insulin to a different form.
Okay.
These three things should be. What we usually do is, if the patient sugar has come down,
Hmm.
he is not able to take fluids, orals by any reason, we
Hmm.
give them DNS infusion, dextrose infusion,
Hmm.
along with 2 units per hour of insulin infusion. So that patient is getting a sugar also, he is getting insulin also. This is when the patient is not taking the fix. So this is again continuation of insulin infusion, right? The
Okay.
patient sugars has fallen, but is not able to take feeds now. We are continuing insulin infusion. But when sugars fall below 250, we have to supplement sugars also. So we are giving a sugar-based solution plus 2 units per hour of insulin infusion. This is a fixed rate. Why not 5D? We'll discuss fluids in another day. 5D will cause dehydration.
Okay.
Okay, giving just 5D will cause dehydration. So giving a DNS will be a better option.
Okay.
Okay. Suppose patient is taking feeds. Patient is able to take feeds means there's no
Hmm.
point in giving DNS, right?
Hmm.
So we have to shift over to insulin subcutaneous. That is our ultimate aim.
Hmm.
So how to give insulin subcutaneous? For that, you have to calculate the total units of insulin given to you.
Okay.
For example, the patient was getting 6 units per hour for 6 hours. This was the total dose of insulin given. So how many units has been given till now totally? 36 units, right?
Hmm.
Plus you would have given a stat dose of 6. So the total units of insulin given was 42 units.
Okay.
This is the total dose of insulin given. Among this, 50% of the dose, that is 21 units, should be given as a basal insulin. Basal insulin is a long-acting insulin. Either a Lantus insulin or NPH insulin should be given.
This, can you please explain what is the
Understood? Yeah. So what are the criteria for stopping insulin infusion? Yes, patient is clinically better. He is not
Hmm.
acidotic. Blood
Hmm.
ketone has fallen. Sugar value
Hmm.
is less than 250. This is the criteria
Hmm.
to stop insulin infusion. So before stopping insulin infusion, because once you stop insulin infusion, his sugar is going to rise again. So we
Hmm.
have to give them an insulin
Hmm.
supplementation. Always
Okay.
remember one fact: the physiological insulin secretion is always a basal insulin secretion.
Hmm.
They have to replace the basal insulin. So to replace that, first calculate the total units of insulin given through infusion
Hmm.
totally.
Hmm.
So initially when the patient has come, you would have given 0.1 units per kg as IV stat. For a
Hmm.
60 kg person, it is 6 units. Then
Hmm.
assume that 0.1 units per kg per hour was given for 6 hours.
Hmm.
So for the same person, 60 kg person, we would have given 6 units per hour for 6 hours. So 36 plus 6 will be 42 units. So this is the total units of insulin which are given for this patient as a DKA management. Of this total unit of insulin, 50% of the dose, you have to give it subcutaneously as a long-acting insulin or an intermediate-acting insulin, right? Understood till now?
Yes.
Okay. So, in short, if the patient has received 42 units of insulin till now through an infusion, 50% of the dose, that is 21 units, you have to give it as subcutaneous, Lantus insulin. But if you are giving NPH insulin, what is the problem? I told you NPH will start acting only after 2 hours.
2 hours.
Right? So if you give NPH insulin, you have to stop the insulin infusion after 2 hours. You are giving Lantus insulin, which is very easy. It will start acting in 1 hour. No. So that is a thing, it's accepted. So the general thing says that if you are planning to stop insulin infusion, so sugar has fallen less than 250, you are continuing insulin infusion. We are planning to stop insulin infusion means 2 hours prior to stopping the insulin infusion, give NPH insulin. Which, what is the dose? 50% of the total.
50% of the total.
50% of the total infusion given. Then 2 hours after that, you have to stop the insulin infusion.
Okay.
Oh, so that means if you are planning to give NPH, we have to give this 50% of the dose 2 hours before stopping the
before stopping the insulin.
Yes. Yeah. That. Okay.
Okay.
So that's also prior to stopping insulin, you have to give NPH insulin. 50% of the dose of total insulin as basal insulin prior to stopping insulin infusion. Then the remaining will be based upon your calculation, guessed calculation. So the remaining will be 21 units, right? That 21 units you divide into 3 for your 3 meals and give it as short-acting insulin or ultra-short-acting insulin. Right?
Okay.
So before stopping insulin, we are given 21 units as basal. The remaining 21 we are divided into 3 and we are planning it to give prior to every meal as a short-acting insulin. Then you have to see the sugar in the next meal. Suppose if it is not controlled, you have to increase the next unit by 2 units. Okay, suppose morning 1 o'clock he has taken the meal, we are given 7 units at that time. Before the next meal, the sugar has to be normal. But after prior to lunch, you are seeing the sugars, it is still 300. What you have to do, the actual dose we are planning to give it as 9 units or 10 units. Then see the next value.
Okay.
Okay. So this is how it rate. So
Just 1 second. Just 1 second. Can I just pause the recording?
Sorry.
Just 1 second.
Check.
Okay. So this finishes DKA management. Then the fourth step in DKA management will be bicarbonate.
Just one more doubt.
Bicarbonate is a dangerous one. Yeah.
We are giving sub-Q 7 units, 7 units, 7 units, and according to that, we'll change. So this also.
I will tell you the titration later. I'll tell you the titration later. That's a different topic. It comes later.
Sure.
Okay. Bicarbonate indications for bicarbonate is pH less than 7. Bicarbonate less than 10. Only then you have to give bicarbonate. Just remember the values. Fifth one is treat the cause. Usually some infection or MI will be the cause for DKA, so treat the cause. So fluids, then potassium, third is insulin. HHS is the same thing, give fluids, but not as aggressive as that in DKA. Potassium, because you are going to insulin. Here also, in HHS also you give insulin, same thing, 0.1 units per kg stat, but the dose of insulin infusion will be 0.05 units per kg per hour.
Okay.
Because the fall here will be rapid. Okay, DK will take a long time to correct. The sugar will be very resistant to fall in DK. Whereas in HHS, it will fall very rapidly. So the infusion dose will be half that is in DK.
One doubt,
So this finishes. Yeah.
How we will diagnose HHS?
Sugars more than 500. Okay. Osmolality more than 310, I think, in the absence of acetone, in the absence of acidosis. So just a high sugars with high osmolality, that is HHS. Patients clinically come with confusion. Usually DKA does not cause confusion, whereas HHS
Oh.
patients come with a confused state or coma.
Mhm.
Okay.
Mm.
Similarly, DKA usually the sugar values do not cross more than 500, whereas
Okay.
HHS it will be 700, 800,000. You have seen patients with 1000 sugar, right?
Yeah.
Yes.
Usually do
Yeah.
not have DKA. It usually will be HHS.
Okay.
So
In
HHS
HHS, the
presentation
fluid
will be
requirement is
confusion.
more.
Yeah. Okay. Any more doubts here in emergency, diabetic emergencies?
Okay,
No.
Now coming to the most awaited and the most
Most
important
awaited.
thing.
Yeah. Yeah.
Initiate insulin treatment as OP.
Yes.
For an OP patient, how to give insulin. Insulin treatment as outpatient. Okay. So hope I'll finish this in 1 hour. Still
Yes.
energetic now, all of you.
Yes. Yes.
yes, yes.
If you understood the first basics, then this will be very, very easy. Okay.
Yeah. Just understood.
First thing we'll be discussing how to initiate and titrate. There are 3 terms. Okay. One is initiation, titration, intensivity. So these are 3 terms which you should understand. Then management of single value hyperglycemia. Suppose you are monitoring sugar, only one value is high.
Mm.
So how to treat that? Single value hyperglycemia, how to treat.
Yeah.
Next is counting insulin constantly. We'll discuss all these things. Fourth is hypoglycemia, how to treat. Okay. So just before this, a short revision. What are the types of insulin based on duration of action?
Ultra short acting, intermediate, long acting, and very long. Uh, yeah. Continue, Santosh. You want to continue?
Okay. All this is insulin. Types of insulin. And what is premixed insulin or mixed insulin?
It's a mixture
It's
of.
a mixture of 2 different
Mixing
actions. For
two
example,
different
R
insulin.
insulin and N insulin. Yeah. So this comes in different combinations. For example, usually N component only they write N R. Whenever we say 30-70 premix, it means 30% is N insulin, 70% is R insulin. Okay. 50-50, 50% N, 50% R. 25-75, 25% is N, 75% is R. We have 70-30 also. 70% N, 30%. So what's the basic difference between all these things? The component of R.
Components. Oh.
Understand? For example, a 25-75 has more R component. A 50-50 has less of R component. 70-30 has the least R component.
Mm.
So whenever you're writing premix, you should never write only premix. You have to write what combination of premix is available. Because nothing is same, everything is different.
Okay.
We will understand that when we discuss titration. Then what is co-formulation? Yeah, N and R both are soluble. If we mix that, we call it as pre-mixed insulin. It will be already mixed in the syringe.
Mm.
But assume a combination of insulin degludec plus insulin aspart. Both can never be mixed.
Okay.
Okay, because both are some heavy substances. They cannot mix as. So we cannot call this as a premixed insulin.
Okay.
So when you take even if you try to mix these two things, it will never be a mixed solution. It will be separate solutions. They are to mix it prior to using it. So premixed insulin is not co-formulation is nothing but a premixed insulin of long-acting as well as ultra-short-acting analogs. But the thing is, they both never mix. It
Okay.
comes as degaspinol, insulin degas. It's a co-formulation. Both are the same. Okay, but premix is N and R. Co-formulation is deglutide aspartate, like that.
Okay.
So this is about the basics. Okay, we'll start straight away. How to initiate insulin. Remember, initially I told you that basal insulin is the most important thing. Because
Yes.
normally, even if a patient is not eating, he secretes 1 unit per hour of insulin per day. So 24
Yes.
units per day is produced as a basal secretion. That is the most physiological secretion also, which is needed for body function. So whenever you are trying to initiate an insulin, the first insulin which you have to think about is always and always basal insulin.
Okay.
Without starting basal insulin, no diabetes will get controlled. Even if you give 100 units of regular insulin or short-acting insulin per day, it is not at all equal to giving
Yes, sir.
10 units of basal insulin, because 10 units of basal insulin is the physiological one. It helps to control diabetes. So
Yes.
please remember this concept. So there is no point in treating a diabetes without long-acting insulin. Okay. Now how to
Yes.
start? Please remember there are so many protocols available. Body weight-based
Okay.
protocols. There are so many protocols available. What
Mm.
protocol I am discussing is just a modification of RSSPA protocol. I shared it in the group also.
Yeah.
A simple one will be, like for example, a 60 kg person, you have to start with 50% of the dose. Okay, for a 60 kg person, the total units per day of insulin will be 30 units. In that 30 units, 50% will be N insulin, remaining 50% will be R insulin. This is one simple protocol. Right? There are so many protocols. What I am going to tell now is RSSPA protocol. So as per that protocol, you have to initiate insulin at 0.1 units per kg per day or 10 units per day. Okay. Suppose I'll give an example. A patient comes with 50 kg. 50 kg person comes. You are planning to start insulin. So what is the dose you are going to start?
5 units.
Correct. You have started 5 units. Suppose if the weight is not available or you are in a very haste to see the OP, you can start at 10 units.
Okay.
Okay, so what's the first step in initiating insulin? Start a long-acting insulin like a Lantus insulin or an NPH insulin at 0.1 units per kg per day. This is the step number 1. When do you have to start? Morning or night?
Morning.
Night.
Evening.
Thank you.
Remember last night. Remember last class we discussed about hepatic glucose production.
Yes. Yeah, it happens in
Hepatic
the night.
glucose production will be more in the night. So if you give insulin in the night, it will suppress the hepatic glucose production. So that will be even more physiological. So start at 0.1 units per kg per day, once daily in the night.
Okay.
So initiation very simple, right? Start at 10 units per day or 0.1 units per kg per day in the night. Simple.
Yes.
Now, step number 2 is titration. Remember the 2x2 protocol. To titrate insulin, every 2 days, you have to change 2 units. Okay. So to titrate insulin, call the patient 2 days. Every 2 days by 2 units.
Okay.
So call the patient after 2 days.
Okay.
And you remember the targets last week we discussed?
Targets.
HbA1c should be less than 7. FBS, I told you, it is depending upon the risk of hypoglycemia. The patient at low risk of hypoglycemia, less than 140 will be the FBS target. Patient at risk of hypoglycemia, 140 to 180 will be the target.
Oh, yeah. Yeah.
Okay.
Mm.
So ask the patient to come after 2 days. After 2 days, we cannot see HbA1c because it will take 3 months to reflect in HbA1c. So to
Yes.
titrate, what you have to see is fasting plasma glucose. You have to see whether it has come to the target. So target I told you, patient at risk of hypoglycemia 140 to 180, not at risk of hypoglycemia less than 140. Suppose patient has come to the target now, there's no need to titrate. Continue the same unit, 5 units per day in the night. Continue the same unit.
Okay.
Suppose if it is not controlled, suppose 180 should be the target which we are assuming. Patient is still having 220 milligrams per deciliter fasting plasma glucose.
Mm.
Now what do you do? Simple, 2 by 2. Second day you are seeing increase by 2 units. So initially is getting 7 units per day. Now make it as 7 units per day. So 5 units per day, you made it as 7 units per day.
Okay.
Simple.
Sir, can you repeat titration again?
Hmm. Yeah, titration is you have started insulin at 0.1 units per kg per day.
Yeah.
To titrate, follow the 2 by 2 rule.
Okay.
At the second day, you have started on Monday means ask the patient to come on Wednesday
Wednesday.
or Thursday.
Mm.
Okay, Wednesday you ask him to come. Morning you see the fasting plasma glucose.
Okay.
You know the normal target values. Okay,
Yeah.
140 to 180 is the normal target value of fasting plasma glucose.
Mm.
If the FBS you are seeing on Wednesday is in
Mm.
the range 140, it is normal means
Okay.
continue the same units.
Okay. Sure.
There's no need to titrate further. Continue the same.
Okay.
Suppose if it is not controlled, if it is higher means you have to
Okay.
increase by 2 units. Second day,
Sure.
2 units.
Okay.
The same opposite will go for low sugar. So
Okay.
140 to 180. Suppose if
Mm.
it is less than 120,
Mm.
hypoglycemia risk is there. So what you
Mm.
have to do? Reduce by 2 units,
Sure.
right?
Yes.
So if you read that RSSDA document, they'll be giving
Mm.
even more values. For example, if the value is less than 100, now you have to reduce by 4 units.
Okay.
Double, 2 into 2. Similarly, if it is 180 to 220, you have to increase by 2 units. If it is more than 220, you have to increase by 4 units.
Okay.
Understand? 2
Yes.
by 2 protocol is every second day, you have to see the fasting sugar. If the range is 140 to 180, if it is up to 220, increase by 2 units. More than 220, increase by 4 units. If it is less, 110 to 140, reduce by 2 units. If it is less than that, 70 to 110, reduce by 4 units. Okay, everything is multiples of. This will be a easy one to calculate, but books may give other values. For example, at titration, you have to reduce by 10% of the initial value அப்படின்லாம் கொடுத்துருப்பாங்க. That once you become very thorough with this protocol, you can read that one. Okay, 10% of the initial value can be added அப்படின்னு போட்டிருப்பாங்க. That we will discuss in the last. You remember up to this initiation, how to
Yes.
initiate, how to titrate. No
Okay.
doubts here, no?
That FBS
So
less
yeah,
than 140, you said is risk of hypoglycemia. Target.
no, the target I mentioned is if the patient is not at risk of hypoglycemia, the target will be 120 to 140, right? 110 to
Point.
140.
Okay. Okay. Sir.
So in that case, uh, if 70 to 110 is the sugar, you have to reduce by 2 units. If the sugar is less than 70, you have to reduce by 4 units.
Okay.
In the higher range, if you see 140 to 180, if it is there, means you have to increase by 2 units. More than 180, now you have to increase by 4 units based on your target which you are asking.
Okay. Okay.
Okay,
That's
so the
there in
second
the
step is done.
guidelines, right?
Yeah, titrate.
The values.
Yeah, I will go through the guidelines in the end so that you'll have a picture. I have
Sure.
taken the guidelines separately and kept it to show it to you.
Okay. Thank you.
Okay, so done. Initiation, titration.
Mm. Okay.
Third step is the most important thing. Intensity.
Mm.
So you have to titrate it till the sugar comes to the target. Once sugar
Okay.
comes to the target, you need not titrate it again.
Okay.
But the most important step is intensity.
Okay.
It should be done at the end of 3 months. So always remember the time period of 3 months. OHS,
Okay.
the efficacy should be assessed at 3 months. Intensification of insulin should be done at 3. So what is
Okay.
this intensification? Here you have to see HbA1c value.
Okay.
So HbA1c should have come to less than 7. That means only chronic sugar control is good.
Hmm.
If HbA1c is not less than 7, which means our sugar control is not good. In that case, you have to change the regimen itself, right? In
Hmm.
titration, what we did initially, we started a basal only regimen.
Hmm.
Okay, this
Yeah.
regimen is called as a basal only regimen.
Hmm.
We titrated it every second day. But after
Okay.
full titration, if the HbA1c has not fallen, we have
Hmm.
to change the regimen itself. Changing the regimen is called as intensification. So, what are
Okay.
the options for intensification? Can you tell me? Giving basal alone
Hmm.
did not have any effect.
Okay.
Okay, giving
So we
basal alone
can,
did not have any effect. We can add a bolus.
yes.
So, one regimen is called as basal plus regimen. Next
Hmm.
regimen is called as a basal bolus regimen.
Hmm.
Okay, what is basal plus? The same basal insulin is there. For example, we have fixed a basal insulin for a person at 14 units per day. HS.
Okay.
This is the basal insulin he is getting. So
Okay.
00 14N. This is the patient's basal insulin he is getting. But
Okay.
this did not control the sugar. Okay.
Hmm.
So when the HbA1c is less means, next what we'll do the next step, we'll try to find out which part of the day he's having a high sugar.
Hmm.
Okay. That's what you do, that continuous glucose monitoring or a complete glucose profile if you are doing. You find
Yeah.
out that the patient's afternoon meal alone,
Hmm.
that's a high spike in sugar. For
Hmm.
example, fasting blood glucose you do,
Hmm.
HbA1c is 9, please remember that. The
Hmm.
HbA1c is not in the target, but its
Hmm.
FBS is 126. It's in the range, 110 to 140.
Okay.
You do a pre-lunch.
Hmm.
Pre-lunch, the sugar value is 340.
Hmm.
You do a pre-dinner. Pre-dinner is 141.
Okay.
Okay, like this you are getting a picture. So it is very clear that this pre-lunch value alone is right. The other two is fairly okay,
Okay.
right?
Yeah.
So the cause for this uncontrolled HbA1c is this pre-lunch value. Last week we
Okay.
discussed about high glycemic variability. Remember, Indian diets will have such a high glycemic variability.
Yeah.
So
Excuse me,
we
sir.
found out that is pre-lunch.
Less than 1 minute left.
Okay,
Okay, okay.
we'll close and close.
Yeah.
Okay, so in this example, is pre-lunch value alone is higher. So what we can do is we can continue the same bowl basal regimen, 14 units in the night, but we need to cover an additional insulin at this time, right? So
Yes.
adding only a bolus insulin for this meal. So how will this regimen be? 0. Morning nothing we are giving. We are giving
Hmm.
few units of regular insulin or a short acting insulin in the afternoon. Followed
Hmm.
by we are giving the base insulin of 14 units of N or a long acting insulin in the night. This is called as a
Okay.
basal plus regimen. So
Okay.
that's a basal plus just one additional. Basal bolus is we are giving a basal plus for every meal we are giving a bolus, right? So there is one basal like 14 in the night, followed every 3 meals we are giving some regular insulin, 8 units, 10 units, 12 units. I'll tell you how to calculate the dose. Okay,
Okay.
this is a basal bolus. Okay, but giving so many tricks is not affordable
Yeah.
or not acceptable. We can do.
Okay.
We can mix the
Okay.
insulin and right. So pre-mixed
Yes.
insulin is one method of intensification. Correct?
Yes.
Okay.
Yeah. Or pre-mixed insulin, if it is not there, you can use a co-formulation. Degar. So again, I'm
Okay.
telling you, there's no difference between pre-mixed insulin and co-formulation. It's only the substance which you are using, it's same. So RNN combination is a pre-mixed. the glutathione aspartate will be a co-formulation.
Co-formulation.
The fifth option for intensification is
Hmm.
you can add another injector, the GLP-1 receptor agonist, semaglutide liraglutide can be used because it is more physiological. Remember last week we discussed about DPP4 inhibition and GLP-1 receptor agonist. Incretin-based therapies are more physiological. So we can give GLP-1 receptor agonist. It will be more physiological in controlling sugars. Or sixth option is continue the same dose of insulin, but we can do some modifications in the drugs.
Okay.
Okay. For example, patient had stopped metformin for some reason. He is getting a combination of vildagliptin plus insulin. Okay, if such a situation is there, we can add metformin first because metformin is an insulin sensitizer. So if you add metformin to any insulin, it will enhance the action of insulin. Right?
Okay.
Similarly, we can add a DPP4
Doubt.
inhibitor.
So with this basal plus and basal bolus in regime, no. Can we give metformin?
Yeah, definitely we can use. Because
Initially
one of the
itself,
indications is failed 3 drugs, right? So patient is taking metformin plus vildagliptin plus dapagliflozin. For them, if you are continuing insulin, this cannot be an option. Already is getting some drugs. Suppose if you are starting insulin itself initially, still it's not under control. In the second step, we can add metformin. I told you, drugs causing hypoglycemia should not be given with insulin.
my
Sulfonylureas
question is
cannot be
that
used.
no.
Metformin can be used.
Even when we start insulin, no, can we give metformin along with insulin at the time of initiation
Yeah, we
itself?
can give.
Yes, yes. Okay.
Depending on the situation, if the patient is already on drugs like metformin, you are adding insulin as an add-on, he's already getting metformin. You can add like that. You can. Hello.
Yeah.
Hello. So,
This is just a hard and fast rule I'm telling. Anyway, patients will be already taking 3 drugs. We'll be adding insulin as the 4th drug only. So he'll be this option will be just a theoretical consideration because already they'll be on drugs.
Okay.
Suppose very rarely a patient wants to start on insulin first
On
itself
insulin.
means
Yeah.
in the second instance we can give this one. Yeah. Okay. These
so
two options we will not discuss
that means
today.
no, if we are starting insulin after 3 drugs, we have to continue that three drugs along with this insulin,
Yeah.
no?
Along with insulin.
Okay.
Okay. So basal plus basal bolus pre-mixed. Okay. Now, what's the dose of starting basal insulin? I told you 0.1 units per kg.
0.1. Yeah.
0.1 units per kg. Some say 0.2 units per kg. Anyway, 0.1 units is best to start. Similarly, for our insulin also, how to initiate? That is for basal insulin, how to initiate? Same thing. 0.1 units per kg or a blind value of 4 units per kg.
Okay. Hello.
This is also
Hello.
0.1 units per kg per minute. Yeah.
Yeah. Okay.
Hello.
Yeah.
Okay. So that basal insulin we started at 0.1 units per kg per day.
Yes.
Or 10 units per day. Here we are starting the minimum 4 units per meal or 0.1 units per kg, the same. So again, for a 50 kg or 60 kg person, the one bolus we can add a 60 kg. The same titration only, 2 by 2. So every 2 days, you have to see the sugar value. If it is not under control, you have to increase by 2 units. The same titration.
Okay.
Right? So basal plus basal bolus 50. What about premix insulin? Premix insulin, I already told you regarding the combination, right? 30-70.
Yeah.
Okay. 40-60, 50-50. something is like.
Hmm.
Suppose if you are initiating premix insulin in the first itself, the same thing only. 0.1 units per kg is the first one.
Okay.
Because mixed studies insulin we are usually starting now the same regimen only, 0.1 units per kg. So for a
Okay.
70 kg person, if you are starting premix insulin, start at 7 units per day. Usually
Okay.
7 units is a low dose. So you titrate and assume that he comes to 16 units per day. Premix
Okay.
insulin you have to give us twice daily, right? The morning we are
Okay.
giving 8 units, night you are giving 8 units.
What
So
is this
assume that
16 units?
8
How
units
it
will
came
start
16 units?
morning. Assuming to
Example.
titration, I titrate.
Assuming?
Example, I titrated to 16.
After
We
titrating.
Okay.
started at 7 and titrated to 16 after
Okay. Okay.
titrating. Okay, assume that he's in a dose of 8 units and 8 units. Okay, we are
Okay.
titrated to this dose. At the end of 3 months, we are seeing the HbA1c level. HbA1c is not controlled. So what can you do? For plain basal insulin, basal plus or basal bolus was there. Okay, now suppose if you are initiated on a premixed insulin, we have to change
Hmm.
or intensify this premixed insulin. How can you intensify premixed insulin?
Add a bolus
The
to
same
start
thing.
acting. Hmm.
HbA1c is 9.
Hmm.
Already he is having a bolus only. Premix is
Oh.
already having a bolus with him. Again,
Okay.
another is there. No.
Yeah. Yeah.
One thing, we can change the twice daily to thrice daily.
Okay.
80 units, 80 units, 80 units. Like that you can change. So change the BD regimen to a TDS regimen. That is one possibility.
Okay.
Another simple thing is you have to see the sugar values. For example, fasting is 146 target, pre-lunch is 312,
Hmm.
or 2 hours postprandial. Similarly, in the evening time also it is around 260. So fasting is
Okay.
under control, whereas following every meal it is increased. That is what is
Okay.
obvious from the sugar value, right? So
Yeah.
what you have to do is, it is very clear that we have to increase the bolus in this case.
Okay.
So if the patient is initially getting 70-30 combination, 70 and 30 R if he is getting, we can
Hmm.
change this to a higher R regimen. We can change it to a 50-50 regimen.
Okay. My doubt is,
Clear?
you said the sugars is 312, 260. It is very clear that it is a
Hmm.
bolus that we have to increase. Why?
Uh, this is postprandial alignment,
Okay.
post breakfast,
Postprandial. Oh.
post lunch,
Okay.
postprandial,
Oh.
postprandial. So
Sure.
fasting is normal. So there's no problem with the basal control. The problem with the
Okay. Like
post
that.
meal control. So
Sure.
we
Sure.
increase the this one.
R. Okay. 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 Okay.
Yeah, that's all. So initiation, intensive titration, and intensification.
Okay.
What is over basalization? You can never use basal insulin more than 0.5 units per kg per day. I told you to start at 0.1 units per kg per day. No, then I told you to titrate every 2 days by 2 units.
Yeah.
Finally, assume that a 60 kg person gets 30 units on titration,
Okay.
0.5 units per kg. You can never go beyond that. So putting 60
Oh.
units of basal insulin for a 60 kg person is wrong. Okay, so
Oh.
never put basal insulin more than 0.5 units per kg per day. Suppose if
Okay.
they go for such a situation, change the regimen. Basal bolus, basal plus, or go to a
Okay.
GLP-1 receptor agonist. Understood
Okay.
something?
Yeah.
Okay. Okay.
Okay, then we'll do one thing. I'll show you the protocols.
Okay.
You are seeing no, able to see no?
Yeah. Yeah. Yeah.
Yes.
Yeah.
Okay, we'll go through this protocol once. Then I'll tell you the
Okay.
special situation.
Sure.
Okay.
See, the first step is if you are starting insulin, always start with the basal insulin, a long-acting insulin. Already, as Firdaus asked, patients already will be usually on drugs, metformin plus some other drugs we are starting.
Yeah.
Okay. The table says for HbA1c less than 8, we have to start at 0.1 to 0.2 units per kg per day. If HbA1c is more than 8, you have to start at 0.2 to 0.3 units per kg per day. Practical purpose,
Okay.
remember one value, 0.1 units per kg per day. Okay.
Okay.
Preferably at bedtime. That also explained to reduce the nocturnal hepatitis.
Yeah.
So we are initiated.
That's
We are initiated at 0.1 to 0.2 units per kg per day.
okay.
Titration should be done by 2/2 protocol. So titrate every 2 to 3 days to reach the glycemic goal. You know what is the glycemic goal, right?
Yes.
Assume that 140 to 180.
Okay.
Okay, actually here they are given 110 to 140 is the goal, whatever it is. So this is the one I told you. You have to change, increase by 2 units or increase by 4 units or decrease by 2 units or decrease by 4 units. This is one value. Or to be more specific, you can add increase by 10%, increase by 20%, like that. For example, fasting plasma glucose is more than 180. So target is assumed to be 110 to 130. If it is more than 130, increase by 4 units. Correct?
Okay.
It's not given there. 110 to 130 is assumed to be the target. If it is more than 180, add 4 units. If it is 140 to 180, it's a little higher than the target, so add 2 units. Suppose within target abdina, you can leave it as such. Suppose if they go for hypoglycemia, blood glucose less than 70, reduce by 2 units. Blood glucose less than 40, reduce by 4 units. You can think about 2 units, 4 units, it will be very easy to remember. Otherwise, think of 20% increase, 10% increase, 10% decrease, 20% decrease.
Okay.
No doubt here, no initiation, how to initiate, how to titrate the basal. Then
Here, no,
you have to
actually,
see the glycemic goals after 3 days.
in practice, no, when this sugar comes below 100, 50, 70, 40, and all, no, we usually don't give insulin now.
Correct. Nice question. But if the patient is actually most of the patients which we are seeing are chronic patients on insulin, so we stop them. But this is initiating and titrating regimen. So in that case, we have to see for hypoglycemia and change the regimen accordingly. Because we are starting insulin for a definite need. Because if for hypoglycemia, if you stop insulin permanently, they'll go for hyperglycemia in future. That's why you're asking them to come every 2 days and titrate. Suppose they are already on an insulin regimen, they are going for hypoglycemia. Assume that that regimen is strong and you temporarily withhold and restart again.
My doubt is that
That's
no,
what we do.
If it is less than 70, no. Okay, we have reduced it by 10 to 20%. So say 10 units we are giving. We are reduced. We are reduced to 10 to 20%. So we are giving 6 units. If the blood glucose is less than 70, no, patient will anyway will go for hyper. No.
Nice question. I will answer this later for you.
Okay.
But you are correct because usually we stop the dose. But it may mean we should not stop the dose.
But our professors here usually tell not to stop. But everybody stops it.
Already 70, 40.
The idea of initiating insulin itself is we are titrating the regimen. The patient comes with a symptom of hypoglycemia, it is different. Patient has some sickness, he comes with hypoglycemia, it is an indication to stop. That's the treatment for hypoglycemia. But we are in a titration regimen. We are trying to titrate what glucose best suits the patient. So he goes for hypoglycemia under our monitoring.
Okay.
We are trying to find out the dose which is best for the patient, so we can reduce.
Okay.
That's my explanation. Do you have any other controversies? Your question is a very good question. No, your question was a very good question. Because practically when we see a low sugar, we'll be afraid and we'll stop. What I feel is patients on a chronic regimen coming with hypoglycemia, the thing is different. But in this case, we are trying to titrate the regimen. So I think in that case, hypoglycemia is allowed. Allowed in the sense we are changing.
Okay.
Okay. And never forget this point. Consider discontinuing or reducing the dose of sulfonylurea after starting basal. That also we are discussing. Then at the end of 3 months, you are again seeing the glycemic goals. This is the intensification phase. So
Okay.
suppose if the glycemic goals are not met, what are the possibilities? You have to add a prandial insulin before the largest one. That is called as the basal plus regimen. So how to start? 0.1 units per kg or 4 units or 10% of basal dose.
This basal plus only.
Okay. Basal plus before the largest meal, one meal, afternoon meal. Okay. Okay. Suppose if basal plus regimen there is no glycemic control, we are adding more than 2 rapid acting insulin injection before meals. That is basal bolus, right? One basal, one bolus will be basal plus regimen. If still patient is not getting control with basal plus regimen, we are trying to become it as a basal bolus regimen. How to start the bolus regimen? 0.1 units per kg before the largest meal or 4 units as such. This is one method. Now come to the middle. Add GLP-1 receptor agonist or SGLT2 inhibitor or DPP-4 inhibitor. I told you, adding some drugs like that. Okay. Come to the rightmost side. Suppose basal insulin alone is not there. Again, one of the possible ways to do is premix insulin. Remember, premix insulin can be used as an initiation regimen also. It can be used as an intensification regimen also. So I told you, so basal insulin not controlled, change to premix insulin BD. Premix insulin twice daily, it's not controlled, make it as premix insulin TDS. Or try to change the type of the premix insulin. 30-70 to 70-30 can be changed to 50-50 or 25-75 like that. So change to premix insulin twice daily before breakfast and supper. Divide the current meal in. You can divide the total dose like this: 2/3 in the morning, 1/3 in the night, or half in the morning, half in the night. Both are accepted. Suppose twice daily premix is not working, change it to 3 times. So clear with this? This is OP based initiation of insulin. So first thing is start basal insulin, titrate it every 2 days, not controlled. See HbA1c at the end of 3 months. Start basal plus, not controlled, basal bolus. Or go for a twice daily premix, then go for a thrice daily premix. Okay, premix and beg co-formulation both are the same. This is the overall one, including last week's class. Start with lifestyle modification. Start with metformin, which is the first drug I already told you. So failure to reach HbA1c target after 3 months of metformin monotherapy. So remember the 3 months target always. So if there's a failure to achieve the target, you have to see the HbA1c. Suppose it's just a little higher, 7 to 7.6. So I already told you, every drug will reduce HbA1c by around 1 grams per percent, right? So if it is just a mild elevation, 7 to 7.5, we can add another drug. So metformin plus OAD or GLP-1 receptor agonist. Suppose if HbA1c is very high, more than 9 means we cannot add 2 more drugs. We can start with insulin based on the HbA1c, right? Here values are given differently. You can practically think it as 7 is the target. If one drug doesn't bring it to 7, it is 8 means you can try adding another drug to bring it by 1. If it is 9, better consider insulin. If it is 10, it is definitely insulin. Okay, so that's all. So you can either add the drugs, 1 drug or 2 drugs, or go for metformin plus an insulin. Here the regimen they are given is premix insulin, but remember you can start with basal insulin also. The other things I think you can read. So HbA1c should be reached less than 7. Suppose if target is achieved, continue the same. Otherwise, titrate the regimen. Titrate it and intensify it. Okay, this is what we discussed. The regimens are given here. You can read it. Steps for intensification. Okay. Any doubts here? The major part is over.
So, good.
Okay, the last 15 minutes only. So 3 minutes you can take a break.
Yes.
Last 15 minutes is the special situations. Any doubts
Okay.
you can ask at the time.
Okay.
Something you understood?
Yes. Something definitely. Last part I need to hear again for better uh,
You
because
can read the chapter fully. It will be good for you.
yeah.
Okay.
Okay, so this finishes the major concept. So we have started how to titrate intensify regimens in OP. At least you will have some confidence now. Okay,
Yes.
for whom to give long-acting lantus insulin, for whom we have to add a basal regimen like apidra insulin plus lantus, whom to give. Then what is
Yes.
the meaning of degas? Okay, it's nothing but a co-formulation. It's used as an
Okay.
intensification regimen. Then
Mm.
basal regimen fails. Then
Okay.
premix insulin is again used as an intensification regimen. It can be used as initiation also. It can be
Mm.
used as intensification also. Twice daily when to give thrice daily, and
Mm.
what combination to give. Okay. Now coming to some special situations.
Okay.
Single value hypertension.
Yes.
This is a very common problem, right? They don't come
Yeah.
in acidosis. They have
Mm.
a very controlled sugar. Suddenly they have taken a very high meal or they have skipped some dose of insulin. Now
Mm.
they come with a sugar of 346.
Okay.
Now this value you have to reduce it back to the normal state. So what will you do? So there's something called as counting insulin. What is that is
Mm.
500. Okay, it's average value divided by total daily dose. Assume that the patient is taking 50 units of insulin per day. So 500 divided by 50 will be 10. So what this counting insulin means is 10 milligrams of glucose is reduced by 1 unit of insulin. Okay, this is the insulin correction factor, ICF, insulin correction factor or counting insulin concept. Okay,
Okay.
so usually what they say is 1 unit of insulin will reduce glucose by 10. It is not always for everyone. It depends
Okay.
upon the particular patient. Okay, so I'll give another example. The patient is taking insulin in this one R8, R10, R8, N20, 0, N30 is taking like this.
Okay.
Okay, remember, N can be given twice daily also. I told you it is preferable to give in the night. Some divide
Yeah.
it also. And what's the total unit he is taking?
26.
6, 16 plus.
How much?
76.
60, 68, 76.
Yes.
So what's the insulin correction factor now? 500 divided by 76.
Okay.
How much it comes? Some 8, I think.
Mm.
Okay.
That means 8 milligrams per deciliter is reduced by 1 unit of insulin. Okay. Now coming to the first example, patient's insulin sensitivity factor is 10 or insulin correction factor is 10. So 1 unit reduces 10 milligrams of glucose. Patient sugar is 346. My target is 180. Okay. So he is in excess of 166 milligrams per deciliter, right?
Okay.
I told you 1 unit reduces by 10. So to reduce 166, I should give 16.6 units of insulin, correct?
Okay.
Okay.
Okay. Good.
This
Where
Good.
is
is
called as
where
insulin
is that
correction factor.
where is that 180 from? Sorry, I lost that. 180, where did that come from?
180 is the target. 180 is our target,
Okay.
patient's target. But
Mm.
instead of being 180, single value is 346. If we are
Okay.
given a work to reduce this 346 to the normal value before the next meal, you have to calculate the insulin sensitivity factor. Okay, if
Okay.
he previously was very controlled with insulin, 500 divided by the total dose of insulin will give the insulin sensitivity factor. That is how much milligrams of deciliter of glucose is reduced by 1 unit of insulin. Correspondingly, you can give the insulin.
Okay.
Okay, understood this concept, single value hyperglycemia or counting insulin concept. This is
Yes.
very relevant than calculating the meal because some patients will go to marriage houses and eat a single meal very high.
Hmm.
In that case, it's generally said that 10 grams to 15 grams of carbohydrates
Hmm.
is neutralized by 1 unit of insulin. So if it is possible to calculate the how many grams of carbohydrate they have consumed, we can give that excess insulin for it. Suppose they consumed 200 grams of carbohydrates,
Hmm.
they have to give 20 units of insulin extra.
Okay.
This should be done if you are able to calculate the amount of uh, carbohydrate in the meal. But that is practically not possible most of the time. So
Yes.
it is better to go for this single value hyperglycemia counting insulin.
But actually, this thing, no, it is
Mm.
possible only
Mm.
for those patients taking insulin, no.
Yeah.
So those
Yeah,
patients,
this is everything about insulin.
okay, so those patients come, on OHA coming after one biryani meal, we can't do anything, no.
We can't do anything. Usually they won't, patients well controlled with OHS will not go for sudden hyperglycemia. They'll not come to the hospital at all, first of all.
Okay, okay, okay.
Yeah. Next is
Where did
variation
they,
of
where did
insulin.
they get that 500 from?
500 is a constant. I
Okay.
don't know the reason even. It is a constant.
Okay.
Okay, next is variation of insulin. So again, I'm repeating. This is only based on the RSSDA guidelines. There are so
Yes.
many regimens. Okay,
Hmm.
weight-based
Yeah.
regimens are there, or simple mind-based regimens are there. Sliding scale regimens are there. So many regimens are
Yeah.
there. Okay,
Yeah.
practically, diabetes is like a max.
Hmm.
I'll tell you one regimen. Uh,
Hmm.
R8, N8,
Just 10 minutes
00.
left. Huh?
Okay, we will finish.
Yeah.
This is one regimen given by my diabetologist.
Okay.
N he didn't give it in the night. He gave
Hmm.
one R in the morning. So this is a basal plus regimen. Okay.
Hmm. Hmm.
But why he gave this regimen is he told one explanation. I told you N
Hmm.
acts for 18 hours, right?
Yeah.
So this will cover till the night time.
Okay.
This R, N takes 2 hours to act.
Yeah.
This R will cover that 2 hours.
Oh,
It's
like
like
that.
a complete 24 hours cover. So
Very
morning
logical.
8 o'clock, if you are giving this insulin,
Hmm.
8 o'clock to 10 o'clock, R will cover. N will start
Oh.
acting from that and will take over the next 18 hours. Again, morning
Oh.
sugar will become high. We'll give R8 and reduce.
Hmm.
Okay.
So this is just a calculation. This doesn't fit into anything. Okay.
Okay.
Similarly, I told you N preferably you have to give in the night time to reduce the hepatic glucose output. But
Yeah.
many people use N morning and night. So if you are starting at 10 units per day, rather than
Hmm.
giving it completely in the night, some give it 5 units in the morning and 5 units in the night.
Okay.
So everything is accepted. But the only thing is
Hmm.
try to be as physiological as possible. That's the only thing. So every insulin regimen is correct. That's no hard and fast rule to start
Hmm.
things. But
Hmm.
follow some standard regimen so that
Hmm.
titration will be easier if you think some.
Okay,
Okay.
okay.
Then what is there? I think I finished.
Okay.
Special situation, hypoglycemia, the last one. You know the three
Yeah.
effects, no?
Yeah.
Homology phenomenon.
And
Normally don't affect.
yeah.
What is waning effect? This is also single
Yeah.
valley hyperglycemia.
Okay.
Homology is hypoglycemia induced
Hmm.
hyperglycemia.
Okay.
All these are causes for early morning hyperglycemia. Okay. So morning
Okay.
sugar is not controlled. Rather than
Hmm.
trying to change the N regimen, night regimen, you have to think what may be the cause. This is early
Okay.
morning hyperglycemia due to high growth hormone. This is common in type 1 diabetics. Type 1 diabetics are usually children. Children will
Hmm.
have a cortisol surge in the morning, growth hormone surge in the morning. So they'll be having Down syndrome. Waning phenomenon is hyperglycemia due to inadequate night dose of insulin. How will you differentiate these three?
Check the
2
midnight.
a.m. sugars.
Yeah. Yeah.
Yeah, midnight and 2 a.m. sugars. So Somogy is hypoglycemia induced hyperglycemia. So 2 a.m. sugars will be hypoglycemia. Dawn phenomenon is just an early morning hyperglycemia due to morning surge of hormones. So 2 a.m. sugars will be normal.
Hmm.
Waning phenomenon is due to inadequate night dose of insulin. Morning hyperglycemia due to inadequate night dose. So 2 a.m. sugars will be high. How will you treat each?
For
For
Somo,
homology phenomenon,
we will reduce the night dosage.
nice. So night, if you are giving N14, he is going for hypoglycemia. You have to reduce. How much you will
Yes.
reduce? 2 units, right?
2 units.
Titration factor, 2 units. Or 20%, 10 to 20% from the initial dose. 20% எவ்வளோ வரும்? Again, some 2 units only it will become. Okay.
Okay.
Okay. What will you do for dawn phenomenon?
Increase.
Dawn is increased morning dose only. Either you can do two things. You can increase the night dose itself. I told you night dose will start covering the morning also. No. So
Yeah.
either you can increase the night dose or
Mm.
introduce a morning dose.
Okay.
Introduce a morning basal dose. Both are correct. You have to reduce the morning sugar. Either you can start from the night itself or start from the morning itself. Both are right. What will you do for the waning phenomenon due to inadequate night dose? For this, definitely you must start high night dose.
Okay.
Okay, that finishes the class.
Okay.
Okay, any doubts? Anyone want to summarize?
Daniel,
Yeah. Daniel, should we summarize from the start?
Whatever you understood initially.
okay.
Start 2 minutes.
Actually,
Insulin.
insulin is, yeah.
Hmm.
Okay. So insulin, ultra short acting, intermediate acting, long acting, ultra long acting. Ultra short acting is Lispro, Aspart, and Glolison. Glolison is Apidra. Short acting is regular insulin, Atrapid. Intermediate NPH. Long acting, Glargine, called as Lantus and Determin. Ultra long acting, Degludec. Then we learned about the onset of action, peak action and duration of action of each. Intermediate is what we have to remember. There is onset of action is 2 hours, and then duration is 18 hours. Long acting, there is no peak to remember that, and also basal secretion of insulin per day. Physiological is 1 unit per hour, that is 24 units per day. Even if we don't eat, it is like that. And then bolus secretion of insulin, that is mm, hello.
Based on every meal.
Yeah, my earphones battery is getting over. Okay. Everything is getting over. But yeah, so long-acting insulin is used as basal that we already saw. Next best that I forgot to say is NPH. Then mm, did I say about bolus? Yeah,
Yeah,
bolus
you
can
told.
be regular or ultra short-acting. Then management of diabetic emergencies we studied. DKA, sugars more than 300, acetone positive, pH less than 7.25. Something called walking ketosis that we studied. And remember always that insulin shouldn't be started first. Always go with fluids. Fluids NS is preferred. And we saw 2 pint over 1 hour, 2 hour, 4 hour, 8 hours. Basically 50% over for 6 hours and the rest over 24 hours we should give. Total deficit is around 4 to 6 liters. Next, the earphone will go now. Potassium, I'll speak till then. Potassium supplementation is a must, especially potassium low. How to give 2 ampoules in 1 pint NS over 4 hours. Potassium normal also we have to give the half the dose, that is 1 pint, 1 ampule in 1 pint NS. Then insulin, how we should start is zero point 0.1 units per kg of insulin, sub-Q or IV or IM, preferred IV or IM. We learned about that. Then criteria for stopping in okay, should I continue, DK? You gave example now that I'm not saying.
No, that's it.
Yeah. Criteria for stopping insulin infusion is when patient is clinically better, blood ketone falls, sugar less than 250, and whether able to take feeds. The first three is very important. And talked about giving DNS not 5% exposed, and 15 to sub-Q insulin also we talked about. Then by it's less than 7 or bicarb less than 10, we can give soda bicarb. also learned
Usually
about
what they say
emergencies.
is, the second day or third day, we can change the NS fluid to a half NS because we have already loaded them with so much of sodium. So sodium will start rising in the second day of decay. So you can change
Okay.
the fluid to half normal saline
So
based
it
on
will end now.
experience only.
I think you
That's
can
all you
conclude.
can
It will end now.
do. Okay. And
Less than
chronic
30 seconds.
OP management of insulin will be initiation, intense titration, and intensification, and the specifications.
That we studied detailedly.
Okay.
Okay. So
Yeah.
thank you so much.
It was a
Okay.
very nice
Okay.
class.
Very nice class. Very
Some
useful. Okay. So thank you
Yeah, at
once
least some
again.
confidence you would have got
no,
it
no,
Yes.
based on what
it was class.
the name.
Definitely. Yeah. Okay.